Hi, my name is Holly Ernst, and I am going to be performing a cardiovascular lung assessment today. I'm going to start by first washing my hands. Before we make any contact with the patient, this is the number one thing all nurses need to do, so that we don't transfer any germs to our patients. Hello, Cameron. My name is Holly Ernst. I'm a registered nurse. How are you today?
Doing good, how are you?
Very good. Could you please start by stating your name and your date of birth?
My name is Cameron Mayu, and my birthday is September 4th, 1973.
Very good. I'm going to be doing a cardiovascular lung assessment on you, where I will be assessing your posterior lung fields as well as your anterior lung fields. Is that okay?
Yes.
Okay, wonderful. I'm going to start with the posterior aspect, Cameron, and then when I assess the anterior, I'm going to have you lie down here on the exam table, okay? Okay. So, first thing I want to do is I just want to inspect the skin. I want to make sure that his scapula is symmetrical. I want to make sure that I don't see any depressions, any bulges. I see a nice lordosis of his cervical and lumbar spine. Certainly no deformities such as kyphosis, which is a humpback, or excuse me, scoliosis, which is like an S shape of the spine. And then I come around to the side here and I kind of look at the lateral view. Could you put your hands forward just a little bit for me, Cameron? Perfect. So he has a good elliptical shaped chest. His AP is more narrow than the lateral. I don't see any barrel chest or any depression in his chest, which is pectus carentum, or the pectus excavation is a depression, and the carentum is a bulge, like a pigeon chest. So now I'm going to go back here, and I am going to just kind of assess his respiratory rate. I want to make sure that there is no labored breathing, that there is no diaphragmatic breathing or costal breathing, no pierced lip breathing. I don't see any cyanosis whatsoever or nasal flaring. I don't hear any stridor. I am going to now just kind of monitor his respiratory rate for any effort. And he has a normal respiratory pattern. Now I am going to just kind of point out some landmarks on the spine that are important. This is the C7 and the T1, and these are part of the vertebral spinous. And why these are important is because starting at T3 through T10 of the spine, that is where we hear our lower lobe lung sounds. Anything from T3 and above, right in this area, we're hearing the upper lobe. So in the posterior aspect, it's just the upper and lower lobe that we can listen to. So next thing I want to do is I want to just palpate to check for any tenderness, any crepitus. I'm feeling for any lumps, any lesions. Cameron, do you feel anything tender?
No.
Okay, great. Next, I'm going to check for symmetric expansion to make sure that both his lungs are expanding equally and symmetrically. Cameron, could you take a deep breath? And exhale. Very good. Next, I want to percuss, and I'm listening for a low-pitched, clear, hollow sound, would indicate a normal lung sound. Good symmetrical resonance in both lung fields. Good. So that sounds normal. I don't hear any density or anything that would indicate consolidation. So next, I am going to just have you, when I put my hands on you, Cameron, just say 99.
99, 99, 99.
Excellent. Okay, so he has good vibration throughout with tactile fremitus. which does indicate no consolidation or abnormalities of the lung. Now I'm going to listen. Please take a deep breath, Cameron, for me, in and out through your mouth. Very good. So the lung sounds that we listen to in the back, well, the lung sounds that we listen to front and back are usually vesicular lung sounds, which are found right here. The bronchovesicular lung sounds are heard close to the spine, right up here above the T3 level, same with the anterior, and then the bronchial sounds are heard here right in the tracheal area. So now I'm going to, Cameron, if you don't mind, I am going to have you, excuse me, stand up and lie down on the exam table for me. Excellent. Okay. So now, Cameron, what I want to do here is I am going to just inspect your skin. Okay, I don't see any lesions. I noticed that you had on the spine a large tattoo, and you have several tattoos here on the torso and bilateral upper extremities. So I am just going to inspect and palpate for any tenderness. Let me know if you feel anything that's sore, okay? No? No soreness? Excellent. I didn't feel any crepitus. Now I'm going to percuss. Excellent. Now I'm going to check for the tactile fremitus in the front now, Cameron. Could you please say 99?
99,
Good.
99,
Good.
99,
Good.
99, 99, 99.
Excellent. Okay. Now I'm going to, excuse me, I'm going to auscultate the vesicular breath sounds on the anterior aspect. First I want to point out, though, some of the landmarks on the anterior aspect. One is the suprasternal notch, which is this U shape that we see right here just below the trachea. And then the sternal angle, which is right here. When you stand, you can kind of see that. And of course the breastbone, which is the sternum. And then the costal angle, which is right here, which is where the ribs end. And that's important because when we're listening to breath sounds in the front, the breath sounds that are above the second rib are going to be the, right here close to the sternum will be the bronchovesicular breath sounds, and we will hear those down the sternal border. And then here we'll hear the bronchial breath sounds, and then most of the assessment, or all of our assessment on the anterior aspect, is going to be vesicular. So I will listen. Deep breath in and out through your mouth, Cameron. Now with the anterior aspect, the right lobe does have 3 lobes. So we are mostly listening to upper sounds on the front. Our upper lobe here, and then when we get down to about the 5th and 6th rib, then we go into the lower lobe, or I'm sorry, the 5th rib is the middle lobe. Down around the 6th and lower, or 7th Lower sixth and seventh, we're listening to the lower lobe. And Cameron is clear in both lobes bilaterally. Okay, next I want to just measure the bronchophony and what we call egophony and the whispered pectoral void. So if you would, Cameron, just say 99 for me.
99, 99, 99, 99, 99, 99.
Good. And what I want to hear with these tests is I want to hear kind of a muffled sound. I don't want to hear anything that's real crisp and clear because that could indicate consolidation or fluid or something in the lung where the sound waves can travel through. Now if you would say E.
E, 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 E,
Good.
E.
Egophony is normal. And I'm going to have you whisper 1, 2, 3. Excellent. Okay, Cameron, now I want to just inspect. I don't see any scars or anything where Cameron has had surgery in the past, any implanted devices, no pacemaker scars. I don't see any heave or lift on the sternal border or the apex. I am looking, or I'm going to look for any apical impulse. Okay, and I'm going to palpate that apical impulse. Okay, and now I'm just going to take a listen to that to make sure that I don't hear any turbulent blood flow or a thrill. Palpating for the thrill. And I don't feel anything, so that means that Cameron doesn't have any murmurs. Next, I am just going to look at his carotid artery pulsation. I am going to palpate that. I'm noticing here as I'm on the right side that Cameron does not have any jugular extension or distension. So that is normal. I'm just going to take a listen to his carotid artery here. I'm listening for any bruits, which is like a swishing sound. Okay, same thing with this carotid. Good. And I'm doing that with the bell of the stethoscope. Okay. Which would be this side of the stethoscope. Okay. Now I am going to be assessing Cameron's heart sounds. I want to hear good S1, S2 sounds. Abnormalities would be any S3, S4, any murmurs. I'm going to start with his aortic valve here. Go over to his pulmonic. Come down to the tricuspid. And over to the mitral. Okay, very good. I am going to now come down to Cameron's lower extremities, and I am going to assess for any peripheral edema or pitting edema, which can be measured on a 1+ to 4+ scale. I do not see anything at all there. I am going to now look at his bronchial pulse. I'm going to come back up here to the hands. I want to feel for a radial pulse, make sure that these are bilateral. Very good. Then I'm going to look for a brachial. I'm feeling for the elasticity of the vessel. I'm feeling for the force. His 2+ is normal. And then for the quality. Okay. I'm going to come down here to the popliteal. Sometimes we have to do one at a time here because these are hard to find. Good. Good. Down to the dorsalis pedis and the posterior tibial. Excellent. Okay, Cameron. He's got good cap refill in both toes. Good cap refill without clubbing on his fingers. All right, if you turn your palm for me, I'm just going to occlude both your radial and ulnar artery, and then I'm going to release one at a time to check for collateral circulation in your upper extremity. So if you pump your hand for me. Okay, let it go. Good. One more time. Let it go. Excellent. Come around and I'll do the same to Cameron's left hand. Pump for me. Let it go. Very good. And again. Relax. Perfect. So that shows that Cameron has good bilateral collateral circulation. He's got good peripheral circulation, no blockage or occlusions, which could indicate arterial disease. And that basically concludes my assessment for today. Thank you, Cameron, for allowing me to work with you.
You're welcome.
And have a wonderful day.